the bottom with the controls? Ah, you got it.
I think I got it now. I think we're now recording.
It's being recorded.
So apologies for that. Let me just bring the slides back up for everybody.
Oh, I guess we have to.
There we go. And you just tell me when you want me to move them forward, and I'll do so.
Okay, thank you, Eddie, and thank you to the webinar team for inviting us to share a little bit about our learnings, our challenges, our successes around a fully integrated sort of client and family-centered engagement program within our organization. As Eddie said, my name is Nadia Tanel, and I'm with my colleague, Beth Dangerfield, and we work intimately in this space and are excited to share with you. So for context, maybe next slide, please, Eddie. You're doing that, right? Yeah, okay. Just for very, very brief context, I wanted to set the stage so you can understand the environment for which we were able to develop and implement a program that we did. So Holland Bloorview is Canada's largest children's rehabilitation hospital. We are a top 40 research hospital fully affiliated with the University of Toronto, and we see over 8,000 clients and families every year with a variety of different diagnoses, over 1,000 different diagnoses every single year, but some of the main children that we see are children with cerebral palsy, acquired brain injury, autism, and muscular dystrophies. And we see both inpatients and outpatients. Within our hospital, we also have a fully embedded research institute with 43 scientists and investigators. Maybe just next page, next slide, Eddie. Thank you. And these scientists are in, from a multitude of disciplines, everything from engineering to social sciences, applied health scientists, and physicians as well. And the primary work that they do is really applied clinical research with a focus on improving the lives of children and families with disabilities. And we have three main areas of focus. We explore human dimensions of health and disability. We look at developing and improving interventions for children with disabilities. And we look to understand developmental diversity. Just to give you a very brief sense of our size or order of magnitude, we bring in about $6.5 million of external research funding every year and publish about 88 to 90 peer-reviewed publications. Just sort of size-wise, that's where we are. So next slide. As Keith mentioned, we have been very fortunate to be in an organization that has such a robust history of client and family partnership. You can see from this slide here that we first started engaging families as early as 1989. And so when we started to think about family engagement in research, we had a huge history and expertise to really pull from. The majority of the work that we had done before 2013 was really in client and family-centered care and partnership within the care parameters. And so it wasn't until 2013 when we really made that leap into formalizing a research partnership program. Next slide. And that leap, that leap sort of evolved from a question that our VPR asked us in 2013, and I'm sure many VPRs and research administrators and scientists across the research institutes are asking the same question. And what he asked us was, we know how impactful and important partnership is in the research, in the clinical realm. Why aren't we doing this in research? All the work that we do is for our clients and families. Why aren't we engaging them from the beginning? And that's what really sort of spearheaded or started our journey of development and learning. And that's how we took the leap. And so the first thing we did was turn to the experts. We turned to our client and family integrated care team, and we turned to our families. And we said, what can we do? How can we create a program where clients and families are fully embedded within our research institute and everything that we do? And so we brought 10 families together, the initial 10 families, and we had a robust discussion with them about client and family engagement and what that could look like in the research context. And the first thing that they said to us was, we need a lot more information. We need to understand the research process from start to finish. We need to understand research ethics. We need to understand the granting process. We need to understand what type of research you do, why you do it. The process itself was relatively foreign to them. They knew that we did research. They knew about some of the research areas we were doing, but they didn't know, it could take 10 years minimum to get research into practice. They had a lot of questions. And so that's what we spent the first 6 to 8 months doing, is education. And from that education, we were able to turn then to this group of now 10 very educated family leaders in the research process and say, where do we go from here? How do we engage meaningfully and authentically? And they gave us sort of 3 areas of focus. They said, establish a working group that will advise you on a regular basis and oversee research engagement at Holland Bloorview, develop a framework or a process and a set of roles for families to engage and partner, and then develop a process for matching, for partnering. How do we introduce clients and families to research and to research teams? And so that is the process or the framework that we've created. And I'm going to turn it over to Beth, who lives and breathes it every day, to really go through these different elements of our program.
So I am a family partnership specialist on the client and family integrated care team. And I'm also a parent of a client. So I bring a lot of lived experience as well as the professional experience to this role. So I think that lived experience piece is really, really important. So the working group that Nadia was referring to is what we call the Research Family Engagement Committee, or the RFEC, as we refer to it here a lot of the times. The membership of that committee is 50% family leaders and then 50% Holland Bloorview staff. And so that staff, we have various staff members on there. We have CFIC leadership, our vice president of research, scientists, and as well as our communication partners from within the Research Institute. We have family leaders who act as a part of the executive committee on the RFEC, and so we have a co-chair, and we have a vice chair, and actually our secretary this year is a staff member. And my role as family partnership specialist, I support the Research Family Engagement Committee, and our role or our mandate is to really advise and make recommendations to the Institute and to the staff on everything related to family engagement and research at Holland Bloorview. So, and when we're talking about family engagement and research, of course, we're talking about the role of clients and families in the research process, well beyond the role of participants in research. So Eddie, I'll just get you to go to the next slide. Thank you. And so moving forward with that second recommendation, the RFEC created this framework which consists of these 3 roles, which are ways in which family leaders from the Family Leadership Program can engage as partners in the research process. So that first role is a research reviewer, which is meant to be a sort of a one-time consultative role. A research advisor is really probably where we see the most engagement happening. It's a very flexible role, and it takes different shape based on whatever request is coming from the staff member to partner with the family. And then we have a communicator role, which really focuses on the dissemination of research results and assistance in producing knowledge translation products. So are the roles that exist within the framework here at Holland Bloorview. I'll get you to go to the next slide. And so the third recommendation from when the initial group came together in 2013 is our request and matching process. And this is very much a space that I live in every single day and where a lot of my focus is. When staff members want to partner with a family, what they do is they would fill out a request form. Our request form lives on our intranet. And so they would, although a lot of staff members actually just have the form saved to their computer because they're using it a lot. But so they would get this form, they would fill out the form, and then they send it directly to myself. I review and evaluate all of the research requests that come in. We have another family partnership specialist that really focuses on partnerships that happen within the hospital. So my focus obviously here is working on research. I review and evaluate and often have a lot of conversations with the staff member during this process to really understand the request and understand what the staff needs in terms of a patient partner. And then I look right to our group of family leaders. We have about 130 active family leaders at this point. And so I look to that group of family leaders and I look for a person who I feel would be a good match on many different levels, and that depends on the specific request coming in. And there's a lot of different factors that come into play about the request, and also just about what family leaders are interested in, their availability, what their experience is in terms of their lived experience. I identify the family leader that would be a great match, and then I pitch the opportunity to the family leader. The family leader has time to, of course, ask questions, understand the role a little bit better, whether that's through me or if they need further information from the staff member. And then they decide whether it's something that they can take on. And if it is, then I facilitate a connection between the staff member and the family leader. And then I provide resources to both staff and family leader from a partnership perspective. So once this process is finished, I sort of exit the process at this point in a way, but I am available to fully support the partnership, and I do check-ins with our family leaders and with our staff to check in and see how things are going. And I also ask for follow-up at the end of the partnership, or sometimes I will remember and I'll check in with them at the end.
So Eddie, I noticed that there are a few questions that are popping up. Do we want to address those questions now, or would you like us to wait until the end, or how do you want that to work?
Well, I will unmute myself. Yeah, we'll hold off on the questions right now. What we'll do is we'll let yourselves and Denis talk about what it is you're doing, and then we'll try and bring things together so that we can see where there's collaboration, things that might be relevant to everybody.
All right, great. So we can move to the next slide. So this is you can click a couple times.
Yeah, just click a couple times for us. There's animation here.
There's lots of animation. There we go. So the framework and the roles that the RFEC created has really led to the success of this program. So these are some metrics that we have from between 2014 and 2018. So we had over 350 families engaged in the research process via the Family Leadership Program and with our family leaders. I always like to say too that we know that engagement does happen outside of this process as well. So we know that there are more family leaders engaged than these numbers are reflecting, because a lot of researchers have established relationships with families and have been engaging families for a long time. Something else that's wonderful is that we have over 50% of our researchers from our various different labs engaging families through the Family Leadership Program. So that's a really important statistic to me, or metric to me. Just means that we're doing it in a way where researchers feel that it's working. 50% of researchers feel that it's working. We're going to work on the other 50%. But anyway, and through our framework, our family leaders have been involved in all aspects of the BRI, whether that's priority setting activities sort of at the beginning of the research process, committees and advisory activities throughout the research process, as well as at the end of the research process when it comes to the communication piece, really across the board. We're very proud of how our family leaders have been involved from beginning to end. We can move to the next slide. We can move to the next slide if that's okay, Eddie. Thank you.
Just trying.
That's good. Oh.
It's always the way. As soon as you do something on the screen.
So I can just start. Yeah. In 2018, we conducted an external evaluation of our family engagement in research program. And it provided us with a lot of information sort of on what we're doing right, where we need to go. And it was really, really valuable, and it's definitely shaped where we are and what we're doing right now. We learned a lot through interviews with family leaders, with staff, and with researchers about the enablers and challenges when it comes to family engagement and research. And some of these are really specific to researchers in the research process. And these other enablers here that you're looking at refer a lot more to like from a structural or organizational standpoint. So I'll highlight those. And this will be very high level, but always, of course, we can take as many questions as there are afterwards. We know that flexibility within the program is very, very important, that it is not a one-size-fits-all type of a process. It can't be. We know that effective matching is really important. So having a devoted coordinator is really working and getting to know both the request, the family leaders, and the staff. Having that person there as a resource too is very important. Buy-in from the top is essential. So we know that is very important, and also having the program centralized within the client and family integrated care team and a very close working relationship there is also very important. And then we can move to the next slide where we learned a lot about our challenges as well. Of course, time to do family engagement in research authentically and to do it well, it does take more time. And so that can be challenging. Our researchers told us they want sort of more information about ethics guidelines. They want more standardized process, and they really think about the impacts of engaging in the research process on family leaders, and are those impacts negative? And then we also know that family engagement in research, we discovered and we learned that it shouldn't be a checkbox. So mandating it in terms of having it be really process driven can cause tokenism or lead to tokenism and inauthenticity. And then, of course, a question that we're always thinking about is the diversity among family leaders. You want to make sure that that the voices that are coming forward and the voices that are providing input, that they're really representing our population and representing the people that we serve. We're always working towards better diversity within the family leadership program and the family leaders that are contributing.
So the last thing we wanted to just leave with you or share with you is really around what we understand to be the impact specific to our program. So when we did this evaluation in 2018, it was really important for us to understand what benefits were coming out of the program that we had initiated. We needed to do this for a variety of reasons. We've been hearing anecdotally from researchers, from clients and families, this is great, it's working, there are so many benefits, but we did need some validation from that perspective. But we also appreciate and understand that there isn't a lot of rigorous or systematic data to support the impact or the benefit of engagement. And so our researchers were asking us, well, what is the benefit? Or is there benefit? And like Beth mentioned, is there potential harm? And how do we know we are truly doing the best we can for our clients and families in this process? So as part of the evaluation, we sought to understand within our institutional program, what are the benefits? And what we heard from researchers was that family input and partnership really improved their research question, improved their data collection, improved their knowledge translation. There's something very compelling about a family leader explaining the impact and application of the research to different audiences, especially non-academic audiences. We heard from researchers that family engagement during the grant process really helped them secure funding, that families involved really influenced new scientists and trainees to really provide with them sort of the greater context. Why are we doing this? What's meaningful? And then another benefit researchers identified to us was that families were expanding their research networks. They were introducing them to different groups that they could gain more insight from, that they could recruit from, and that they could share results with. A few quotes here. The researcher said that the family leader changed our entire research question. We would never have thought of that without them. Or I would never do a project now without them being family leaders. It's been the best thing ever. So we were excited, obviously, that there was some impact and benefit to the research and the research process, but we also needed to understand what this meant for clients and families. And clients and families also overwhelmingly told us that there were significant benefits to them to engage. They felt a sense of making important contributions and making a difference and wanting to provide feedback that would be valuable and help the future of childhood disability research. They described the experience as rewarding. They also told us that it was a different type of engagement that they may not have been not experienced before. And they learned a lot of things that they might not otherwise have learned if they weren't part of this process. It boosted self-confidence. They were contributing again to something meaningful. They also talked about learning a lot. And actually one family said that they were able to put this experience on their CV and it helped contribute to a future job. And lastly, although they came at this understanding that there was no direct benefit to their child or family, indirectly, some of the work and partnership that they did help their understanding of their own child and the experiences they were going through. So, overall, we felt that these were great indicators of success and that there was definitely impact and benefit to our program. This is specific to our program, obviously, but this is a journey. We talked about some of the challenges and we continue to face challenges and try to really, learn throughout the process. Like Beth said, every experience is unique and different. I couldn't help myself but see a question about the messiness of engagement. It is messy and it isn't something, I think we have to live in that messiness in order to be successful. So those are just some of our learnings and our experiences, and really looking forward to hearing from Montfort and the discussion.
Great, thank you. I'm going to pass over to Denis. You probably have to unmute yourself.
Yeah.
There you go.
Eddie and the SPOR unit staff for your invitations to allow me to share the Montfort experience. And I will just start to talk a little bit about the Institut Savoir Montfort, which is the research branch and education branch of the hospital. We have been created in 2012. And the difference between other research institutes is that part of our structure, we work closely with our education partners. So one of our goals is to reduce the time from knowledge generations to knowledge application. So you will see that in many of our research team, we have right away at front a specialist in education that could be set to right away try to help us, even in the research question or tool that we will develop, make sure that it will be easy to develop, and also that will be an efficient tool for knowledge translation. So because we were new, and because the Francophone community are very close to the Montfort Hospital, and we're very close to community health organizations that offer service in both French and English. When we did our strategic plan, we involved right away patients and caregiver, as well as our administrator, the planner, so a representative from most of the organization.
Oh.
With a strategic plan that we want to take care of not only of the body, but as well as the mind. So our research project focused to a better integrations of physical and mental mind. We know that patients with chronic disease have mental health issues, so and the reverse is also true. So we have three main priority. One is better manage comorbidity, like I mentioned, improve health services, access, quality, and safety for patient and French. And go back, yeah. And the third one is education. So and we want to do the research with the patient, but not only the patient, but also for me, it's always very important that the knowledge user also engage and involve at the same time. So at Montfort, they had already, before we launched the Institute, a Montfort patient partner council, a very efficient office that recruit patient, family member. They train them, they make them involved on a regular basis for the business of the hospital. So instead of creating our own association, we had some information on the questionnaire, on the profile, and we invite the patients that wants to be involved in research. So when we need some representation, representative from patients or family member, we go through our administrator of the patient partner. And by doing that, we have also changed, not changed, but engaged patient or family member in all our standard committees. So we have representation on the scientific committee, our advisory committee, and also our grant evaluation committee. And they have the same weight, their score is the same weight as anybody on the team. And based on experience, some of the grants have been sent back and say, we want more voice of the patients. We want to make sure that the question is in line with the needs of the patients. In the meantime, to help develop the capacity, and also we develop some training programs for patients, for the researcher, as well as the administrator, health professional, because they are involved in many of our research projects, as well as the new student, the new generations, all students that came at Montfort. Our goal is that they've been aware that we are doing research, but with patients and with knowledge user. So we develop them and we test them, and we are almost at the end of the evaluation program. So since 2011, because there was some research activity, because before we launched the institute, I would say about 75% of the project have some kind of involvement of knowledge user and patient. But since 2018, for all our internal competition, and we offer about $1 million a year of grant money. And that's a requirement that the patients be involved at the beginning, and they need also to describe what was the participations of the patients and how they've been influenced the question or the design of the protocol. Also, because we built the research structure organization, we have permanent research coordinator. We have 5 of them that are supported directly by the Institute. And we use them as the trainer. So we train them in patient engagement. So they are the one who assist the research team. They are the one also who make the mentoringship for the patients before, during, or after the meeting. So it's take off a little bit of weight on the researcher, not all the weight, but at least we have a person that could make some communications between and better follow up, because sometimes, as you know, researcher can't forget to do some pre-briefing or post-briefing with patients to see if they feel that they are considerate. We also try to implement a little bit more and more systematic way, evaluate the participation of patients through the McMaster evaluation tools. That I think it's a really useful tool to give feedback to both patient as well as the research team if what they are doing in the engagement of the patient or the family member or the knowledge user beneficial for both parties. And that's something we want to study more and use more in our future research. I was glad that you present. I was very impressed by your organization and how you involve the family. I will probably give more an example how we implicated the patients. So Eddie, if you could bring the next slide, please. For me, the whole issue of patient engagement, it's more than a research project. It's part of a health learning system or health learning or learning hospital. So to give you a very concrete example, patient as well as the hospital administrator bring up the notion that many patients in our ward have multiple chronic disease. Patient coming in many times a week, many times in a month to see different health professional. Sometimes family member have to take care of the transportation in Montfort. The average distance people have to do to have access to French services is sometimes between 50 and 70 kilometers. So it's a lot of loads for the family member, especially when they care for their parents. So, and we look also the data in the hospital, and at any time, half of the patients in the hospital have more than one. So the hospital, in line with the patient partner, identify a priority for the hospital to create a new model of care for patients with multiple chronic disease, what we call the Center of Excellence for better management of these patients. And we set up a group which involved the leadership of the hospital. You talk about the importance of having the support. So we have the chief medical officer, the VP professional involved in the discussion about how we develop the new model of care. We have representatives from young patients with multiple chronic disease and also older patients, men and women. And we, knowing that this new model will have to, will involve some change in behavior and how we do things on the clinical practice. So we involve representative of different health professional sections. So through the whole exercise, what we did is we document the problems that have been raised by patients as well as family members, as well as the health profession. And we, yes, we looked the literature, we visit some center, but we always came back to the old groups to give them, share the information, get their feedback. And it took about 2 years with many different type of meeting to develop a new model of care that seems to, at first be able to respond to a better needs of those patients. So we have created 3 type of new model of care: one for patients, hospitalized patients with multimorbidity, one with ambulatory patient with multimorbidity, and we also develop a model for a community approach. So right now we are in the implementations of those 3 pilot projects with regular meeting with the patient partner as well as health professional to make some change on as we go. And the goal is really to implement this new model of care delivery in the daily activity, the new way of taking care in most of the services at the hospital. So that was very productive. And I could say that the participation of the patient was very key to identify and improve care in terms of how we deliver service. We could go at the other slide. So and I think the colleagues mentioned previously, we use also this model to make sure that we involve patients at the start of how we develop the question and through all the step of developing the research proposal and also up to the knowledge translation. To give you another example that how we try to implement and practice this model, go to the next slide, Eddie. We develop a grant competitions, but not for researcher, was for anybody in the hospital, could be a patient, could be a VP, could be an administrator, could be a health professional that have a challenge, clinical challenge. And in that case, it was the director of the postpartum services of the obstetric with their colleagues that have some complaint of mothers that didn't know why they stay at the hospital after 2 kids. They're ready to go very sooner than stay in the hospital, but there was some barrier or some kind of concern about the obstetricians to let them go early. So with that seed money, what we did is we built we identified researcher to be able to develop in collaboration a pilot project and implemented. And when they've been implemented, they also identify new services to be offered in the community. So if you discharge early in the mother, they need some follow-up in the communities. And that's where the midwife services have been more involved. And at the same time, another groups, the pediatrician, they say, well, if you discharge early the mother, what will be the impact on the newborn? And again, we built a research team around this group. And if you look in this slide, in most of the team, we have only one researcher, and all the other team members are knowledge user. So it's a bit the reverse model of what we saw normally. It's mean that normally you have 10 researcher and 1 patient or 1 family member. Here it's really the opposite. And I strongly believe that it's another way of doing research. The other and last thing I wanted to mention is that what we try to do now is that we have patients when you start the question, when you design the protocol. But when we implemented the new model, it's important, and I believe it's important to recruit those who have been exposed not only on the research activity focus group or questionnaire, but identify a few of them to bring them in the teams to help us in terms of data analysis, in terms of knowledge transfer strategy, and so on. So that's where we are thinking the new step that we want to experience in the future. So so that's the experience with the Montfort. Like I said, it's not perfect. It's still a challenge, but we saw less and less resistance, I would say, from researcher. And also, it's important, I think you mentioned it, but it is important to have a large pool of patients so you have some kind of variety to avoid too much influence of a few patients on the old research endeavor, and I think that's quite important. So that's the experience of Montfort.
Great, merci, Denis. That's fantastic. Lots of great questions popping up in the chat box. So I'm going to sort of jump into it with a few of those questions and sort of open them up to both of you. We talked a little bit about the messiness of patient partnership. We talked about evaluating patient partnership a little bit and diversity. What, in terms of the diversity issue that Colleen brought up in the chat box, do you guys have sort of tactics or strategies to try and get at the groups that you don't necessarily always hear from?
Yeah.
At Montfort, it's a challenge because we have much more patient from a high education status, I would say. We try to make to try to reach out to other organizations, especially to have a better diversity in terms of ethnicity. But it's still a challenge to have them on board.
Definitely, I think we can relate completely in terms of that's where we see a lot of our patient partners from similar background. We're trying to understand right now the demographics of who we serve here at Holland Bloorview to understand, and then try to understand where our gaps are and where we need. We're in the process of doing that right now. So I think it's really understanding who we serve and then looking at our group of family leaders and trying to identify where the gaps are and maybe do some targeted recruiting.
Mm-hmm.
But there are situations where a few situations that come up where we can't, the person with the right experience or the person with the right background we don't have the match for it. Happens.
I think another thing that we do is access really increases our ability to diversify, right? And it's very easy for sort of the higher SES stay-at-home mom to come in 3 times a week to advise on a research project. So looking at different ways of engagement, different opportunities. So what might remote engagement look like? What might a one-time advisory role look like? So meeting the clients and families where they're at to ensure that we get some diversity. And as well, training and education. I think participating in the research process is incredibly intimidating. And we've heard that from clients and families. We don't speak that language. They say if you're welcomed into a room of 10 researchers and there's one family there and they're all talking in their jargon, it's intimidating and it's discouraging. So it's training on both fronts, giving the clients and families the language and the resources they need to meaningfully participate, but also taking a step back and talking to and training. I love this research coordinator training model and research training model where how do we best engage clients and families? How do we reduce those barriers so more people can participate?
Fantastic. I'll come back to the training issue in a minute, but one of the things that came out of both of your conversations was the drive for this seeming to come from senior leadership. At Holland Bloorview, you having your VP of research saying, why aren't we doing this? And Denis, you've been very instrumental in sort of pushing this forwards in your leadership role. How important do you think that is for others? Is it possible to do this without that kind of senior leadership drive, or is that kind of an essential component?
Well, I can tell you that at Montfort, all the VP are involved in the research team. And for me, it was important that they be part of the research team because they are the one who make the decisions, and they know if a new model of care is financially will be applicable, do we have the resource? If not, what type of resource we need to have? Do we have the space and all that? And I think that's quite important. And more recently, I realized that because I want, for me, a research institute in a hospital, 50 plus 1% of my project have to answer a daily challenge of the patients, of the health professional administrator. So they need to be involved constantly in our research activity. And my next step is to provide some research funding to the leadership teams So when they have some discussion that raise a question, that they could have some money to push and identify a researcher or few researcher and patients that could help to answer that question.
Fantastic.
Yeah, I think we would agree. I mean, it's hugely influential and important to have that senior leadership buy-in. And we're very fortunate that all our VPs, right up to our CEO, are incredibly engaged and supportive of family partnerships across the organization. And I think without that, it would be very difficult to get the buy-in and the level of engagement that we currently have.
Great. Just quickly, a great point from Annie on the chat box about the ability to use patient partners as a way to reach out to groups you might not necessarily have access to, and I think that's a really valid point that certainly we've heard through OSSU as well. I'm going to combine two questions because it's sort of getting towards the end of our time together. You obviously have been doing this for a while, so I would be interested in hearing sort of the most pertinent piece of advice that you would have to give to a group who are starting out in this, but also to hear about the thing that would have been most helpful to you when you started. They may not be the same thing, but whether there are sort of things that would be you think other people should know, and whether there are things that you either see now or that you would like to see that would really would have helped you start out in this journey.
Oh.
I will let my colleagues go first.
Advice.
I think,
Sure, go ahead.
If I'm thinking of the day-to-day work that I do with with researchers and families who are partnering, I think flexibility is a really important thing within the research context, and listening, like we sort of said before, one size doesn't fit all, and needs vary, and different types of research need different things. And so I think you know, we have a successful program, and we have challenges too, but you know, part of our success comes from the ability to be flexible, and prioritizing being flexible and listening to each other, you know, and listening to families and listening to researchers and what everybody needs, and really the collaboration piece is really important. But flexibility is key, I think, in the work that I'm doing sort of at the front lines, let's say.
Yeah, go ahead.
The only other thing I would add is co-development right from the beginning. We were fortunate to have a group of family leaders and a group of dedicated scientists who helped develop our initial program. You can't develop this in a silo. You can't develop it only with families. You can't develop it only with scientists. You really need, as much as we talk about partnership at the actual research team level, you need partnership at this the program systematic level as well.
Yeah, I totally agree with what you mentioned in terms of flexibility, adaptability, and start at the beginning. My advice will be double your time of preparation, because that's take time. So it's not something you could rush. So you really you have to be visionary a little bit more than what we do our grant right now. Don't wait to have a competition to start to work with patients, and there will be opportunity all the time, and you're going to be more ready and do the real process and benefit of the process. That's the most important thing. And which I would like to have, it's a better strategy to have a more diverse patient profile than we have, and how we could tool that we could reach them more. So that's, for me, it's missing right now.
Great. thanks to everybody on the chat box. There is a specific question from Colleen to Denis, but I will let Colleen. Are you guys happy accepting questions either on Twitter or by email if there are specific questions that come to you?
Absolutely. Yes, for sure. Absolutely.
Yep.
Great.
Yeah.
Certainly. What I will do is Colleen, I will pass your question directly on to Denis. He might be able to give you some specific answers. And I will just quickly go on to the next slide. If it's going to let me. Of course, it's not going to let me. It'll be far too easy. Okay, let's try this again.
Oh, there's.
Let's try the share again and see if that works. There we go. I wanted to do another quick poll at the end here. Do stay around for this because this is how we try and work out what it is we're going to focus on next. So we obviously want to try and go to understand what things that might be of interest to people in the future. So every webinar we do a little thing at the end where we identify a few potential topics, as well as the opportunity to select some others. And as you can see, there's a poll open now with some things that we think might be interesting to talk about as well, that's come from discussions across the patient partner working group and other areas of patient partnership in Ontario. You can choose as many of these as you like. If you're interested in all of them, please feel free to select all of them. So this just helps us sort of think about what we might want to talk about next time that will sort of grab people's attention and might sort of fit the need. If there are other things that you think would be really interesting that you want to hear about, then feel free to either email them to ossu@ossu.ca or tweet them to us at OSSU Tweets. We're always happy to hear about new ideas and new things that might be relevant to discuss. I'm going to leave this open for another sort of 10-15 seconds, and then I'm going to pass over to Keith, who I'm now going to unmute so that he can do a quick thank you. Great, Keith, we still have you on? Oh, Keith sounds like we've lost him.
It's on mute, I think.
I unmuted him and we've lost him as a participant. So okay, I also can't mute him again because he disappeared. So apologies for the beeping. I'll end the polling there. Annette, you were able to do a quick thank you? Let me unmute. There you go. You're unmuted. Now I can hear you.
I'd like to thank the presenters for all the work they put into the presentations that they presented to us. That was really illuminating. I enjoyed Dr. Prud'homme's. I enjoyed hearing about the research that they're doing at L'Hopital Montfort that has more patients in it than researchers. That's a nice change. And I know that Holland Bloorview Kids does a really great job of engaging patients and partners and parents. And so it was great to hear more about how they did it. It's such a friendly place. So thanks again, everybody, and thanks for those in attendance.
Yeah, just to say thank you everyone for participating. As you can see, there's some information in the poll. There's an interest in all of the topics, which is great to see, which means we'll have a bit of a discussion within the patient partner working group about exactly what the next topic will be. You may see these pop up over the next few months as different topics for things that we'll discuss in different areas. Yeah, just to echo Annette, to say thanks to Denis, to Nadia, and to Beth for great presentations and great conversation, and to all of you for being present and asking such interesting questions. And the webinar will be available online, hopefully within the next week or so, with a recording of it. Feel free to share it. Feel free to keep this discussion going in however people want to be involved. Thanks very much, everybody, and I hope you have a great rest of your day.
Thank you.
Yeah, bye-bye, everyone.
Thank you very much. Bye-bye.